All right, let's jump straight into this high-yield explainer. If you're gearing up for your final implantology boards, you already know this chapter's an absolute beast, dense, tricky, and super easy to mix up. But don't sweat it. We're going to break down the exact clinical protocols you are guaranteed to be tested on. By the time we wrap up, you'll have a crystal clear mental map of the whole process. I'm talking from that very first handshake with the patient all the way to torquing down the final prosthetic screw.
Here is your study guide for the session. We're strictly dividing this chapter into 5 heavily tested buckets: systematic patient assessment, radiographic evaluation tools, rules of available bone, biomechanics and stress factors, and prosthetic treatment options. Let's do this.
Section 1. Systematic Patient Assessment. Look, we're starting at square one because skipping a systematic evaluation is literally how nightmares happen in the clinic. Examiners want to see that you are a safe clinician before anything else.
Definitely star this in your notes. These are the systemic conditions that critically mess with bone metabolism and wound healing. We're talking major red flags here: uncontrolled diabetes, being immunocompromised, blood dyscrasias, and impaired cardiovascular function. Oh, and don't forget psychiatric disorders like paranoia or dysmorphobia, plus drug or alcohol dependence. You've got to catch these early because the slickest surgical technique in the world won't save you from a systemic failure to heal.
So how might a multiple-choice question try to trip you up here? Well, test writers love mixing relative risks like, say, heavy smoking, with absolute do-not-pass-go stop signs. For example, if you see recent irradiation of orofacial tissues on your exam, that is a massive glowing red stop sign. That tissue is severely compromised, and putting an implant there is just asking for failure. You have to recognize the difference between a condition you can manage and an absolute contraindication.
Moving past medical history, your actual dental evaluation has to systematically check off these 7 specific boxes before you even think about picking up a handpiece. You've got to check the initial soft tissue, do a deep dive periodontal exam, assess available bone, scrutinize the specific implant site, analyze stresses, look at patient habits, and evaluate any natural abutments. If an exam question asks what precedes the surgical phase, remember this exact checklist.
Moving right along to Section 2, radiographic evaluation tools. Board exams absolutely love testing the clinical applications of different imaging modalities, so let's get into it.
You are almost guaranteed a question asking you to differentiate between 2D and 3D imaging. Remember, a panoramic radiograph is strictly two-dimensional. Yeah, it's super common, but it's only used for the preliminary check of available bone height. You cannot plan a complex 3D surgery on a flat picture. So, a CBCT is absolutely mandatory when you need three-dimensional digital planning. It gives you coronal, sagittal, and panoramic views, letting you literally map out bone quality, and where all your critical structures are hiding.
All right, Section 3, Rules of Available Bone. Grab your highlighters. This section is basically microscopic math and highly tested numbers. Stick with me, we'll do the math together. Let's start with a crazy multiplier. When a patient loses a tooth, the bone loss during that very first year is 10 times greater than in any following year. 10 times. Do not forget that number. That rapid loss wreaks havoc on aesthetics, function, and health, which is exactly why edentulous patients are prime candidates for implants. We want to stop that 10x bone loss dead in its tracks.
When we look at the remaining bone, we use a specific grading scale. You absolutely must know the MISH classification for your exams, know the name, know the definition. Carl Misch created this to classify bone quantity and quality. Division A, that means you have abundant bone, easy day at the office. Division D, severely compromised bone, major challenge.
Just visualize this progression. On one end, you've got that abundant, thick Division A ridge, but as it resorbs, it shrinks all the way down to that tiny, compromised Division D. And here's the kicker. As that ridge resorbs, the muscle attachments actually get closer to the crest. Picture this exact progression when an exam question asks about the anatomical hurdles of Division C or D bone.
Okay, let's talk bone height, measured from the crest of the ridge to whatever opposing landmark is in the way. The golden rule here is you must maintain exactly 2 millimeters of a surgical error margin. That's your safety zone between the implant and something critical, like the maxillary sinus or the inferior alveolar nerve. So if you've got 12 millimeters of bone above the nerve, you can't just jam a 12 millimeter implant in there. You've got to subtract that 2 millimeter safety buffer. Next up is width, measured between the facial and lingual plates. A 4 millimeter diameter root form implant needs more than 5 millimeters of bone width. Why? Because you need enough bone thickness around the implant to keep the blood supply flowing. Without blood supply, you don't get integration. If the exam sets you up with a 4mm implant and a 4mm ridge, boom, you immediately know you're grafting first.
Now let's build on that with bone length or mesiodistal space. An implant has to be at least 1.5 millimeters away from an adjacent tooth. Let's do some quick math. If you're placing a 5mm diameter implant, you need 1.5 millimeters of bone on the mesial and another 1.5 on the distal. Add that up, and your 5mm implant demands a minimum of 8 millimeters of total mesiodistal space. Guarantee you'll see a calculation like this on your boards.
All right, Section 4, Biomechanics and Stress Factors. We're looking at arch forms and the invisible forces that can completely wreck a beautifully placed implant. We have to engineer our treatments to survive the forces of the mouth. First, crown height space. You measure this from the crest of the bone to the plane of occlusion. As bone resorbs, the space naturally gets bigger. If you're planning a removable prosthesis, like an overdenture, you need a minimum of 14 millimeters of space. Why so much? You need room for the acrylic base to actually be strong, plus the attachments, the bars, the denture teeth, and enough space for the patient to actually keep it clean. Less than 14 mils, your materials are going to snap.
Now for a really critical biomechanical rule. Your AP spread. That's the distance from the center of your most anterior implant to a line joining the distal of your two most distal implants. When you place 5 anterior implants in the mandible, your absolute limit for the posterior cantilever is 2 times that AP spread, and that's assuming all other stress factors are low. If you push it past 2x, physics is literally going to rip those implants right out of the bone.
Speaking of physics, let's look at stress factors. Don't let force direction questions trick you. Compressive forces? They're your best friend. Implants handle compression beautifully. Shear forces? Your absolute worst enemy. Also, think about abutment position. The max biting force is always back in the molar region, which is why molars always demand wider implants. Finally, spot parafunction immediately. Bruxism, clenching, tongue thrust, they multiply the forces on your system, and that usually means you need more implants or wider diameters.
And finally, Section 5, Prosthetic Treatment Options. Let's look at the exact fixed versus removable options in your toolkit based on what anatomy the patient has left. I've grouped these so you can focus on the contrasts. Your fixed options range from FP1 to FP3. FP1 just replaces the anatomical crown. FP2 replaces the crown plus a portion of the root. But circle FP3. This one is heavily tested. FP3 uses pink restorative material to replace missing soft tissue. On the flip side, you have RP4. It's totally implant supported, but it is removable. To pull off an RP4, you need a strict minimum number of implants, 5 to 6 in the mandible and 6 to 8 in the maxilla. Drill those numbers into your head.
All right, I'm going to leave you with this provocative thought to tie everything together. If a patient has severe bone resorption, we know their crown height space gets larger. But how does that resorbed, shrunken arch physically alter your available AP spread? And if your AP spread shrinks while your crown height space grows, what exactly happens to your leverage? How does that physical reality force you to abandon an FP1 and pivot toward an FP3 or an RP4? Think through that mechanical cascade. If you can understand that, you won't just pass your exam, you'll truly master implantology. Thanks for hanging out with me on this explainer. Study hard, and I'll catch you on the next one.